Thank you, Sandy. So I'm going to talk about anti-VEGF therapy as the best treatment for proliferative diabetic retinopathy. Now, anti-VEGF treatment has just recently come on the block. It's the first major advance in 40 years for the treatment of PDR. We can take an eye that looks like this with very active NVD, and with one injection, we can transform it into this picture with no active NVD. So we now have a choice of treatment, anti-VEGF or PRP, and that is the basis of this debate. Now, panretinal photocoagulation is an excellent treatment. It's been around for a long time, but it destroys large swaths of retina. It causes peripheral visual field loss, night vision loss, and DME. And we know that it's not perfect. 5% will still suffer severe vision loss despite PRP. Look at this eye with very active NVD and macular traction. This is the same eye 2 days after a single injection, and you can see significant regression of the NVD. This is it at 4 months. The NVD is completely contracted, and the macular traction is relieved. Try doing that with PRP. And this is the same eye 3 months after 6 injections and almost no diabetic retinopathy except the regressed NVD. If you don't believe that, you can look at this patient, high-risk PDR with a preretinal hemorrhage, the same eye after 1 injection with less hemorrhage, same eye after 3 injections, and this is the eye nearly 3 years after this with only 9 injections, and you could never really tell that this eye ever had diabetic retinopathy. What other advantages are there? Well, you can use anti-VEGF in miosis, cataracts, asteroid hyalosis, and vitreous hemorrhage. And if you don't believe that, there was this landmark study, the Protocol S study by the DRCR Retina Network, comparing anti-VEGF to PRP. And it showed at 2 years that there was that anti-VEGF was non-inferior to PRP, but it also showed superior vision over the course of 2 years. This is the visual benefit to the patient during the entire study period, not just at the end. There was less visual field loss and less operations. PRP, well, there were fewer visits, and of course, there were less injections, only in those eyes that had DME. And then we carried this out to 5 years, and it showed that both groups ended up with excellent vision 20/25, but it also showed that the PRP group had a much higher incidence of DME and a much higher rate of retinal detachment. Now, this topic, I know Dr. Elliott's going to bring this up, and of course I had to say this because Mark Johnson's sitting right there in the front row, but we call this noncompliance or loss to follow-up, but it's not just anti-VEGF. PRP is not one and done. Over 50% require more PRP, such as this eye, that got PRP, developed a preretinal hemorrhage, lost to follow-up, and came back with vision loss. And this eye, young male with very active neovascularization, after 2 PRPs, not much change, but you add a little bit of anti-VEGF and voila, it's almost all regressed. And when you look at 5 years, by the 5th year, almost 40% of eyes did not require an injection. And if you don't believe that, this medal was awarded for the best piece of original work for the Clarity study, first time in 10 years, and it showed that anti-VEGF was superior to PRP. So you can take an eye like this on the left with a preretinal hemorrhage and transform it into an eye like this with almost no retinopathy. Dr. Elliott, my patients want wide vistas of vision, not little tiny limited islands of sight. Audience, vote pro.